Hi, good
Hi,
good
everyone.
evening.
Welcome. Good evening. My name is Annie Benzi. I am the chair of the SSAT Complex GI Surgery Fellows Subcommittee. Welcome, everyone, to our last grand rounds of this academic year. Can't believe it's been gone so quickly. We definitely have an interesting topic this evening. And just a little behind the scenes, too. In the next 2 weeks, all of you fellows will be getting an email that will open up the application for our certificate program for this year. So please, when you get that email, please respond. Let me know if you have any questions, concerns. It's the same criteria that we outlined at the beginning of the year. And the sooner that you fill it out, the sooner we can get your certificates to then help you get credentialed in your new jobs too. So if you need anything, any questions, comments, concerns, please just let me know and just be on the lookout for that email over the next week or two. Okay, so tonight, without further ado, we are so excited to have Dr. Kyle Perry join us. He is professor of surgery in the Division of General and Gastrointestinal Surgery, as well as the director of the Comprehensive Esophageal Health Center and associate director for research in the Center for Minimally Invasive Surgery at The Ohio State University. Dr. Perry, thank you so much for agreeing to be our moderator this evening, and if you wouldn't mind, just introduce our fellow.
Right, Annie, thank you very much for the invitation to be here and for all of you for being here to participate. It's a pleasure to be here. I guess if there's questions during this, you can just type them into the chat and we'll try to address them as they come up. We're going to have Event Health in Tampa is going to present this diagnostic situation for us, and we'll talk through how we might approach it and the diagnostic tests we have available. And so we can try to keep it interactive. Feel free to chat questions in, and let's find out what we're going to talk about. Gautam, why don't you go ahead?
Hi, good evening. Thanks for introduction, Dr. Perry and Dr. Benji. I just started when I started the fellowship, we have these Achalasia patients and some stricture patients having most common complaint is dysphagia. But on the top of this non-obstructive dysphagia, there are a lot of motility disorders. And when I started to look about these diagnostic methods we use, one of them is the high resolution manometry, definitely, which is a great test in evaluating all the motility disorders. And when I looked at the words, I thought it's like a soup of words, which is very difficult to understand initially. That led me to an interest to see much of high resolution manometry studies. And I opted this topic that where high resolution manometry along with the newer studies will help us to have an idea about the diagnosis. So let's start our discussion. So the outline is I have a case, we have a discussion about the investigations as we talked, and we have a video how we did the Heller myotomy, and we can talk about Poem versus Hellers for achalasia. But basically our patient is a 24-year-old female who has difficulty with both solids and liquids. By the time she saw us, she lost almost 20 pounds and stayed on liquids. No significant medical history, no medical conditions. So we have an upper GI, but which obviously shows the bird beak appearance with retention of the contrast in the lower esophagus. But I later found that we order mostly a timed barium esophagogram, which obviously is also another new study. I thought but I think it's a regular study, but I heard first time, and I looked into it how they do. They take almost 100 to 250 ml of low density barium sulfate and let the patient drink it in 15 to 20 seconds. And then they obtain the lateral anterior oblique views of the patient after 1 minute and after 2 minutes and after 5 minutes, because in most of the healthy subjects, the contrast should be emptying from the esophagus by 5 minutes. Then we put these films side by side and then draw the upper line, like a horizontal line at the upper border of the contrast, and then calculate the distance between the upper and lower borders, and also calculate the maximum dimension of the esophagus to get an assessment of how much volume of the barium is left in this esophagus. So with the, actually, as I said, like the healthy subjects, in less than 5 minutes, the entire contrast should be cleared from the esophagus. But with the achalasia patients, there is like retention of the barium in the esophagus with the bird beak appearance, and it gives an idea of the functional motility of the patient, how he can clear the contrast. So that's the first investigation we start with when the patient has obstructive symptoms with the esophagogram, make sure there is no like a mechanical obstruction. And then our study of interest is the manometry. Previously, it's a conventional manometry where the sensors are very low in number for every 3 to 5 centimeters. But right now it's a high resolution manometry. And our patient, it says like IRP is 44.1, and there is no peristalsis, and there is no pan-esophageal pressurization, other term, and there is 100% failed bolus clearance. So when I looked into the report, it just says IRP, DCI, DL, CDP, CFP, EGJ, CI, intrabolus pressure. These terms like looks like a little fancy at that time. So I thought like, let's see what each of them is. And that's why I wanted this talk about the high resolution manometry. So it's a with the high resolution manometry is generally combined with the esophageal pressure topography, which is a great evaluation for the esophageal motility disorders. It incorporates up to already 36 pressure sensors placed 1 centimeter apart along the catheter. And this data is converted into a seamless and dynamic spatiotemporal esophageal pressure topography plots by advanced algorithms. How we do is we place the catheter transnasally, and we position it to ideally span the entire length of the esophagus. And the distal sensor should be placed 2 to 3 centimeters below the diaphragm. And we start with the protocol where we get the recording when the patient is not taking or swallowing or anything. It's called the baseline quiescent period. We take it for 30 seconds. And then we ask the patient to drink 10 5 ml room temperature water swallows. Mostly they do in supine position. And this is the thing we need to get from the person, whoever does the procedure, whether the procedure is performed in supine or reclined position. Because the pressures in the reclined position is always less than the supine position. That gives us an idea. And there should be 20-second gap between each swallow, because we need to get the patient back to the basal activity. And that's the component. Deglutitive inhibition is other key component in the esophageal peristalsis. So to get an idea about it. So we need to get in which position it is performed. And then this is the baseline period where we get an idea about the EGJ complex morphology. So EGJ complex consists of 2 components, crural diaphragm and the lower esophageal sphincter. This is the other advantage with the high resolution manometry, where we can have a diagnosis of hiatal hernia based on the morphology. And we also get the upper border of the EGJ complex and lower border of the EGJ complex, which is very important for getting a measurement of integrated relaxation pressure. So this is the baseline. We make sure that catheter is positioned appropriately. If it's not, if you make changes until you get a proper baseline period. And then, just as I said, like we make sure. And this film tells about the normal peristalsis of the esophagus. So as we start swallowing, oropharyngeal phase, which is completely different ball game, we can talk about later time. But once the swallow is initiated and the upper esophageal sphincter is relaxed, then a segmental peristalsis starts and progresses towards the EGJ complex. And it's always a segmental peristalsis. You can see there are like 4 segments in the normal peristalsis of the esophagus. The segment 1 is the striated muscle, and the segment 2 and 3 are part of the distal smooth muscle of the esophagus. And you can see a transition point, which is we call transition zone between the striated and the smooth muscles. Even in the smooth muscle, there are like 2 segments, segments 2 and 3, separated by the trough M. And if you see the pink circle, it points it points to a contractile deflection point. That's the point where exactly the velocity of the peristalsis of the esophagus changes from a peristalsis mode to the sphincter mode, like helps in the ampullary emptying of the foodstuff. So that's the point we need to mark, because it's useful for calculating the distal latency, which is the time gap between the upper esophageal relaxation to the point pink circle, which is called CDP. And we can also calculate the contractile frontal velocity at the point. These 2 black lines are called the isobaric 30 millimeters Hg pressure, bolus pressure. So we can measure the CFP at each point, and we can get this deflection point where the velocity decreases and changes into the EGJ, like ampullary emptying mode. And coming briefly about the innervation, the striated muscle is supplied by the vagus nerve, which has direct innervation in the striated muscle. But when it comes to the smooth muscle, those the blue circles are called, represent the excitatory neurons, and the red dots represent the inhibitory neurons. If you see, the proximal smooth muscle has more excitatory neurons, and distal smooth muscle has more inhibitory neurons. So this is called the inverse neural output, creates a distal latency for the contraction to propagate. And that helps in the sequential segmental peristalsis of the esophagus. That's the normal subject is this diagram A. But in B, there are a lot more excitatory neurons compared to the inhibitory neurons. And these patients will have hypercontractile, which is in future we call it as jackhammer esophagus. And here in this patient, there is complete loss of inhibitory neurons, which obviously these people won't have this deglutitive inhibition, which leads to non-relaxation of the lower esophageal sphincter, which obviously that's the achalasia. And here in the diagram D, there is no neurons, and this is like atonic eperistaltic esophagus. And just what is deglutitive inhibition is nothing but if you initiate swallows sequentially without the completion of the peristalsis of the first swallow, the second swallow can't initiate a peristalsis. So this is very important, and actually the high resolution manometry has these provocative maneuvers where you ask the patient to rapidly swallow, and whenever the deglutitive inhibition is completed, then the next peristalsis will have more force, and it is called peristaltic reserve. Actually, it is calculated to get an assessment in a patients who undergo fundoplication, because peristaltic reserve should be normal for the patient to have good outcome after the fundoplication. And here, this image just like we are taking and combining the fluoroscopic images with the high resolution manometry. If you see, the blue dot is, this dot is the point where the lumen closes. And actually, this is the point that correlates with the positive upspike in the manometry, whereas the white dot represents the intrabolus pressure. And here, this is the first portion where of the segmental peristalsis heading towards the EGJ complex. But if you see, this is 8 seconds into the deglutition window where the intrabolus pressure is starting to reach the EGJ complex, and there is the relaxation of the EGJ. So here, one thing we need to understand is the relaxation is different from opening. Relaxation is just like the LES relaxes, and then the intrabolus pressure should be more than the LES pressure to open it. So this again depends upon a lot of things like intragastric pressure, phases of the respiration, and etc. factors. But just we are correlating the manometry with the fluoroscopic images here. And in this slide, we are calculating the integrated relaxation pressure, which is a key component in the entire classification of the motility disorders. So integrated relaxation pressure is nothing but the lowest pressure of the LES over 4 seconds, which is either continuous or non-continuous, in the deglutition window, starting after the upper esophageal sphincter relaxation. So we take 10 seconds after the upper esophageal relaxation. We create an electronic sleeve that is nothing but the upper border of the EGJ complex and the lower border of the EGJ complex, and document the pressure and calculate the lowest pressure for 4 seconds. And in this case, it is 1.6 millimeters of mercury. But one thing we need to make sure here is this IRP depends upon the system we are using for high resolution manometry. Sierra system designs, the cutoff is 15 millimeters of mercury, while Unisensor designs, the cutoff is 28 millimeters of mercury. So once again, this is another important point we need to get which design we are using for getting the IRP calculation. And here, as we talked, the other two important measurements we make in the high resolution manometry is the latency, distal latency, which is the time period between upper esophageal sphincter relaxation to contractile deflection point, which should be more than 4.5 seconds. If it is less than 4.5, we call it as premature contraction or spastic contraction. And if the 20% of more swallows have distal latency less than 4.5 seconds, then it's called as distal esophageal spasm. And then we calculate the volume of the contraction of the distal esophagus extending from this transition zone to the lower esophageal sphincter, which is the multiplication of the length, pressure, and the time how much the pressure is above 20 millimeters of mercury. This is called distal contractile integral, and it gives a measure of the contractile vigor of the esophagus. The normal is until 450 mmHg/s centimeters to 8,000 mmHg/s centimeters. Anything less than is called either failed or ineffective. Failed is less than 100, ineffective is 100 to 450, and anything above 8,000 is called as hypercontractile esophagus, which is the called also as jackhammer esophagus. And as we go further, if there is a defect in the peristalsis, like more than 5 centimeters, it's called fragmented peristalsis, and it's called as minor motility disorder. And in this right extreme diagram, there is no peristalsis and the DCA is 0. So we call it as failed. The peristalsis failed.
Gonna
And
pause
one
you
other,
there for a second. Sorry, Dr. Sokoto from Ecuador. Thank you for joining us. I think you had some comments or something you wanted to bring up.
so Nutcracker, they say above 5,000, but Jackhammer is above 8,000. That's the only difference I found when I am going through this high resolution manometry.
Dr. Sokoto? Just have to unmute yourself. Sorry.
Sorry, I'm from Ecuador. I just don't want to stop. I want the presenter to continue in order to make a comment later on when he stops, when he finishes the presentation.
Gotcha. Okay. Go ahead. Sorry, Dr. Lingamini.
Yeah. So the other important thing, as we talked, the difference that differentiates from the conventional manometry to high resolution is it gives a idea about the morphology of the EGJ complex, because the EGJ complex is not only the intrinsic pressure from the lower esophageal sphincter, but also there is a contribution of the crura to add to the EGJ complex pressure. So if you see, there are like three types based on EGJ morphology is divided into three types based on the alignment of the crural diaphragm with the lower esophageal sphincter. If they both are in line, as we see in the left side, it's called type 1, and it's normal. If they are separated by 1 to 2 centimeters, we call it as type 2. It's like a mild variant of a hiatal hernia. And if they are separated like more than like 2 centimeters, it is type 3, where in this case it is like 5 centimeters. So this is not incorporated yet into the Chicago classification, but they think like in near future they will just incorporate the EGJ morphology also in the part of Chicago classification. So finally, the checklist is like after individual swallow, we try to measure the integrated relaxation pressure and reposition the landmarks if needed. Yeah, identify the contractile deflection point and measure the distal contractile integral and the distal latency. Measure the spatial breaks when present in the isobaric contour of 20 millimeters of mercury. Assess for the pressurization, and that's the other component. We need to know the pressurization of the intrabolus component. If the pressurization is extending from the upper esophageal sphincter to the EGJ complex, it is above the 30 millimeters mercury bar. It's called as pan-esophageal pressurization, which is one of the diagnostic criteria for type 2 achalasia. And then we synthesize the information, then comes to the put them in the classification system, which is the Chicago classification 3.0, which is getting modified. So we start with the integrated relaxation pressure. If it is above 15 in the CRS system, and there is 100% failed peristalsis, it's the classic type 1 achalasia. If the IRP is high above the normal limits and 20% of the contractions have pan-esophageal pressurization, it's called type 2. And some studies say like this is the evolution of the achalasia, starts with the EGJ obstruction, then advances to type 2 pattern, and then finally ends up with the type 1 pattern. But this type 3 entity, where the 20% of the contractions have latency less than 4.5 seconds, it is the type 3 achalasia. And studies prove any interventions to improve that has less successful outcomes compared to the type 1 and 2. But if they don't fall in this above criteria, where the integrated relaxation pressure is above the normal limits and it doesn't fit the criteria of type 1 to 3 achalasia, then we call it as EGJ outflow obstruction. Definitely, it may be an incompletely expressed achalasia or a complete mechanical obstruction like a stricture. And if the integrated relaxation pressure is normal, then you go and check the distal latency. If 20% of contractions have short distal latency, it's called distal esophageal spasm. And if it's the DCA is above 8,000, it's called jackhammer esophagus. And if they don't have any contractions, then it's called absent contractility. These are all the major disorders of peristalsis. And if there are minor disorders called ineffective motility, where 50% of the swallows have less DCA less than 450. So anything less than 450 is either failed or ineffective. And if there is a fragment greater than 5 centimeters, there's a break in the peristalsis more than 5 centimeters, and 50% of contractions have it, we call it as fragmented peristalsis, which are minor disorders. And I think ineffective motility, I think, has some indication when we are doing the fundoplication procedure. Some studies say you tailor your wrap based on this ineffective motility. Some studies say people prefer to do partial wraps. But I'll leave up to the panel later to discuss about that. And this is how the manometry looks in the achalasia. If you see the left image, it's a classic type 1, where there is no relaxation. And the integrated relaxation pressure is 18.4, and there is no peristalsis recorded. So it's the type 1 classic achalasia. And this middle picture is where there is no EGJ relaxation. IRP is 33.7. And there is a pan esophageal pressurization to 30 millimeters mercury isobaric. And the type 3, as we talked, is no relaxation, but they have more premature contractions called spastic variety. It's just the nutshell of what I told. And if you see the left one here, the distal latency is 3 seconds, which is obviously less than 4.5. And if 20% of swallows have this kind of pattern, we call it as distal esophageal spasm. The right one is nothing but a normal variant, but a rapidly progressive peristalsis. And in this film, the right side shows the DCA is around 16,000, but they have normal latency, and the lower esophageal sphincter relaxes normal. So this is nutcracker esophagus, and these patients have chest pain more. This is just a nutshell of and these are the minor disorders of peristalsis, where I already told ineffective esophageal motility and fragmented peristalsis. And then the other investigation I want to talk is the endoflip, which is functional luminal imaging probe, which is not, so the manometry depends upon the relaxation of the lower esophageal sphincter, whereas the flip technique measures the distensible, like how the lower esophageal sphincter can be distended. So it gives a good idea about the distensible status of the lower esophageal sphincter, and it's called as distensibility index, which is calculated by measuring the cross-sectional area with the pressure generated in the balloon. And now studies are telling if we can use intraoperatively and achieve a good distensibility index with the flip study, those people will have a better outcome. So if you see, it comes in 2 sizes of catheters. One is like 16 centimeters and other is 8 centimeters. In the 16 centimeter catheter, which has a balloon distally, there are like 16 electrodes, and there is a pressure sensor at the end of the catheter. and there are two electrodes at each end, generating a low electric current. And we inflate the balloon with 20 cc of normal saline, then introduce into the patient during the endoscopy, and then get a baseline picture. Right now, they integrated where we can get a real-time image, and we position the catheter distal to the waist, and we reposition frequently during the procedure so that it stays in position. And it as the current flows from the electrodes based on the differences between the electrodes, which is Ohm's law, where voltage is equal to the current into the diameter. We get a good assessment of the diameter of the esophagus and can calculate the pressure in the catheter, which gives a if we integrate all the data at the software level, it gives an idea about the lumen of the esophagus and how it can be distended in relation to the volume expansion of the catheter. So we introduce with 20 ml of normal saline into the patient, and then gradually increase the diameter of the balloon with the 10 ml increments. The maximum used is 70 cc, and we get the idea about the distensibility index. And the hallmark feature of the achalasia is the failure of the lower esophageal sphincter to relax. So the distensibility index is very low in achalasia patients. And actually, when we distend, there is a secondary peristalsis that happens in the distal esophagus, and it's a normal pattern, is repetitive antegrade contractions. So this is the secondary peristalsis that happens when we distend the lower esophageal sphincter. And we know that there is a transient lower esophageal sphincter relaxation, and if it gets worse, they will have gastroesophageal reflux disease. Actually, these secondary repetitive antegrade contractions are very crucial in clearing the acid during the transient episodes of relaxation. So that's the normal pattern of the flip panometry. So this is the high resolution manometry showing the repetitive contractions. But this is when we distend, we get the these peristalsis, secondary peristalsis in the esophagus, and this is achalasia, where the distensibility is very low and there is no contractions recorded, either primary or secondary. And this is type 2 and type 3. Same thing. We can't like distend the EGJ complex, but there are some fan esophageal pressurization waves, and these are like the spastic waves. So this is the study that proved the distensibility index measurements during the Heller myotomy and POEM procedure for achalasia. They predict the post-operative outcomes. And it shows like if there is a higher distensibility index after the procedure, those patients will have better outcomes. And also, the flip study is very useful when there is a true EGJ outflow obstruction, because this is the slide that shows patients with the elevated IR, like integrated relaxation pressure in all the 3 cases. But if you do the flip, there is the distensibility index is very low and there is no peristalsis, and it correlates with the fluoroscopic image. But in this patient, where the IRP is high and distensibility is low, but if you do the fluoroscopic, it's like the spasmodic esophagus, like contracting simultaneously at all levels, causing the patient's symptoms. And if you see the third scenario, where the integrated relaxation pressure is more than 15 millimeters of Hg, but if you see the flip study, the distensibility index is normal with normal peristalsis, like the secondary peristalsis. And the ECG has no obstruction. The liquid and tablet clearance happened normally. And also,
Just pause for a second. Let's just kind of talk about this a little bit. So for everyone attendings or fellows otherwise on the call, if you want to just comment, like, do you use EndoFlip as a adjunct or in lieu of your high resolution manometry, or how have you been using it intraoperatively at your centers? Open to anyone.
I guess, are
So
you? Oh, go ahead.
No, go ahead. No, thanks again for that very comprehensive review. So Annie, I'll ask you a question. So you know I'm a colorectal surgeon, so you can tell me anything and I'll believe it. So, but I'd like to hear from the panel and a lot of seasoned people on the line also, and the fellows, that how they work up in their practice. Somebody with achalasia with all these investigations, and we haven't even talked about an EGD yet. So Annie, I'll start with you, and then we can open up to the group.
Perfect. So I think, traditional practices, a lot of the workup is actually done by GIs, but mine is a little bit different. I actually started a reflux and motility program when I joined my hospital, and now it's in its third year. So I actually start with these patients from the second they Google my name or see me on YouTube or something like that. So I do the full workup pretty much myself. So first I start with a swallow. Depending on what that swallow shows me, I'll do an EGD. If I'm concerned they have some sort of motility issue, I actually will do EGD and then manometry simultaneous. And then I actually have one rare patient now that and this is why I asked this question, her manometry numbers are not classic for achalasia, but when I went down her esophagus, I can see food and she has all the symptoms. So I'm actually bringing her back to do an EndoFlip study as well. So that's pretty much my basic workup for motility issues. But be interested to hear about everyone else's too.
Yeah, I think, are you asking, when you ask about using EndoFlip in lieu of manometry, are you asking in the setting of reflux and motility, or specifically achalasia?
I think just in general motility. Yeah.
Yeah, because I think for achalasia, EndoFlip's pretty good. I mean, when you have someone with a normal appearing mucosa and a tight GE junction, that's pretty good for achalasia. And there's some data from the Northwestern group that may be sufficient to diagnose it. But I don't know. I'd be interested to hear if anyone on the call is doing that. I don't know of anyone who has made that leap to say we're going to abandon manometry. So I think it's mostly been an adjunct. Is secondary peristalsis assessed by EndoFlip adequate for reflux surgery? And the correlation with manometry wasn't as good as we would like it to be to replace manometry. So that's kind of where we are, is that we use it as an adjunct rather than as a replacement. I'd like to hear about anyone else on the call, what they're doing.
Yeah, right now the American Gastroenterology Association said that, yeah, it's a complementary study to manometry, but not like a replacement. But what about the intraoperative flip during a Heller myotomy? Is anybody doing it?
I know we had Mike Ujiki on the call, but I don't know if he jumped off.
We flip on everyone during Heller, and I think it's just really important to do that knowing your insufflation pressure too, and then going to 40 on the flip for the LES portion at least, to make sure that you truly have a good myotomy.
What's the DI cutoff you're using to say that you think you've succeeded?
It's a good question, isn't it? It's relative to where you start from, I think. Because I think if you're going to use EndoFlip, you should start out with it before you do anything and then readdress it. We didn't talk about this much, but Annie knows this, we use EndoFlip to drive our hiatal closure too quite a bit, Dr. Perry. I think the important thing there is that, you can get a good waist. It's the length that's where the wrap really changes things, I think. So you really have to think about this with each patient. But specifically with achalasia, I think we're looking at the difference, basically, especially at 40.
Yeah, I think that what you find with your endoflip when you're looking at an aperistaltic achalasia patient as opposed to a GERD patient with intact peristalsis. I'd like to hear, Mike, I know you have a lot of experience with this. We'd love to hear what you're thinking.
Yeah, this has been great so far. I really have found it very interesting. Thank you, guys. I think that interestingly, what we have found is that the ideal range, whether you have normal peristalsis or not, is really somewhere in that 2.5 to 3.5 range. And so that's what we shoot for. I agree with the comment about it being relative somewhat. But as experience has grown, I'm really kind of feeling that we almost always, whether we're doing a Heller myotomy, whether we're doing a POEM, or whether we're doing a fundoplication hiatal hernia repair, want to leave the procedure room with a distensibility index of around 3, anywhere between 2.5 and 3.5, and I think you'll be in good shape. We absolutely use it during Heller myotomy. I actually leave the balloon just somewhat inflated. The problem is you do have to use bipolar energy, because if you use monopolar energy or anything, it will throw off that current in the balloon. And so only bipolar energy will allow you to actually do a myotomy with the balloon inflated. But it's really kind of nice to watch it in real time, you know, as you release the circular layer and longitudinal layer. You know, the DI will kind of get into that range where you want. But then we of course always do a partial fundoplication. So, you know, if you go a little bit higher, if you get into that 4 or 5 range, it really doesn't matter, because you're just going to tighten it again with the fundoplication.
So you're shooting for the same DI range, whether the patient has achalasia or if you're doing a
Yeah, we just presented this at the Central 2-day on Thursday, actually, or Friday last week, but we just went through all of our data, and we probably have a couple thousand patients now. And what we have found is that whether you have dysmotility or normal motility, the range actually is the same. And that was very counterintuitive to us. For many years, we were just shooting for 2.5 to 3.5 for patients with normal motility. But what we found is that even a patient with ineffective peristalsis, IEM, that 2.5 to 3.5 range is still the best. If you get over 3.6, the recurrence rate is significantly higher for a hiatal hernia, for example. And if you're below it, they're going to have, as you can imagine, more dysphagia, gas bloat, and other symptoms. But what's interesting is, as you can imagine, a patient with dysmotility, if you're below the ideal range, if you're below 2.5, a dysmotility patient will be much worse than a patient with normal motility. But they both do worse than either patient in that ideal range.
But so you have even with a DI of 3?
You kind of broke up there. What was the question?
Is it somebody though, like an achalasia patient who's aperistaltic will still do okay with a DI of 3?
Absolutely.
Yeah. Okay.
So Mike,
as you go
Mike,
too
I wanna-
high, reflux starts to go up. So the perfect number is somewhere in that, like the 3. If you can get it right, but we know we can't do that. But if you're doing a myotomy, 3 is ideal.
So Mike, help me here, because you do POEM and you do Hellers. Why do you rap?
Well, the way I look at it is our POEM patients have twice the GERD rates than our lap Hellers do because of the partial fundoplication. But what I do tell patients is our GERD rate is about 40% after POEM. And that means 60% of patients probably don't need a wrap, right? So a partial, like a door fundoplication, is an outpatient procedure. So we do a POEM, we Bravo everybody a year later, 96-hour Bravo off PPIs. We put everybody on a PPI immediately post-op, whether they have a lap Heller or whether they have a POEM. And we just tell them, continue your antacid for a year. And the reason we do that is that we didn't used to do that. We used to just treat people symptomatically. But the problem with achalasia patients, as probably people here know, is that about half of them who do have GERD after myotomy don't even feel it until they stricture or have problems. So we just put everybody on a PPI. We bring them back in a year to do a Bravo. If they're positive, we give them the option of staying on a PPI or having a partial fundoplication. But if I'm doing a lapeller myotomy and I'm there anyway, I'm going to do a partial fundoplication.
Yeah, no, it's just interesting that you bring that up because it's very unusual that we do two operations. You know, we usually like to reproduce what we do, right? If you do something robotically as open or whatever, it's just a little counterintuitive to me, but thank you for explaining that.
Dr. Sokoto, got your hands up.
Good afternoon. I'm talking you from Ecuador, from South America. In low and middle income countries like mine, it's quite difficult to obtain a high resolution or a flip study. So we add to the technical aspects the epidemiology. In South America, Chile, Peru, Colombia, and Ecuador, we still have a lot of Chagas disease, which is the main cause of achalasia here. So we just have the chance to use an EGT, a varium study, probably a normal manometry in the best of the cases, but with the clinical expectation and with epidemiology, we do in those cases a door and a laparoscopic surgery. So I don't know if we're doing too much surgery on those cases, seeing your excellent presentation, because we don't have the chance to put patients, I mean, we put a lot of patients on achalasia space. So I don't know if we're doing too much surgeries on those patients. That's my question to the audience.
I don't know.
Fernand,
I think it's a very different, yeah, it's a very different situation that you have there than here. So it's a little hard. I think it's almost hard to compare the two. So I think I've been doing this here for 15 years and I've tested one Chagas disease. So I think it's just quite a different different animal. So that's why the workups can be different. And probably, I'm guessing probably you're not. But I thank you very much for being on. It's great to have you here.
I have a question to this is Sharona, regarding those that do POEM. If you have hiatal hernia, would you still do POEM? And, you know, when did you feel like you need the endoflip? I mean, I understand I'm a little bit more old fashioned. I don't have the endoflip. I just do the myotomized segment, making sure that it's well above the G junction, and then I do the endoscopy again and make sure everything is open before and after. So I was just wondering, and I always do a door fundoplication. What do you do when you have hiatal hernia? Do you just follow them for the reflux, or what's your management then for those who do POEM?
We have any takers for that? I could answer, but I sort of shied away from it in the setting of anything larger than a really hernias on pre-op workup. I would do lap hellers. I switched to doing most occasions in response to the reflux problem. So I think one way is what Mike was saying. I sort of went another way and said, I think we should be trying to more aggressively control reflux. So the times I'm using POEM has been much more limited. And I think that endoflip helps, but I mostly work with manometry. I think that endoflip's a great help when you have dysphagia after Heller, when you're trying to figure out what is the problem I'm dealing with now that's causing that to still be a problem. I think where, to me, I think it might be a big help is these patients when we're doing true AJ outflow obstruction for dysphagia. I've done some of those cases where I haven't been so happy after. Oh, I'll try it here. Sorry, I don't know, my connection's not so good. Maybe this will be better. Can you guys hear me now?
Mm-hmm.
I
Yes.
think that when you have the patients with EJ outflow obstruction who have intact distal peristalsis, when we do our normal myotomy, we extend that myotomy up into the segment of their esophagus that's functioning normally and turn it into a poorly functioning segment, and then they have some dysphagia related to that. And so I kind of wonder if using EndoFlip to tailor those myotomies and keep them as short as possible and preserve that functional segment might be a good use of the tool, but I haven't actually done it yet.
Kyle, I agree with you 100%. I actually think that the 3 centimeters onto the stomach and the 5 to 7 centimeters on the esophagus is actually dogma. I actually believe the reason that studies show that those patients were more likely to have their problem fixed is because you were more likely to actually get the sphincter, because we can't really tell where it is externally. And I was taught all the landmarks. I believe it. But now that we have endoscopic options, and now that we're doing a lot of hybrid endoscopy and identifying the GE junction endoscopically while looking laparoscopically, I think we're wrong more than we think. And so I think we're just basically hedging our bets when we do more of a myotomy. But I do think that studies have already shown, randomized controlled trial out of China was very well done, showed that a shorter myotomy led to less reflux when doing a poem. And so I do think that EndoFlip has an opportunity to kind of confirm that we don't need to do more. And I think we can now start doing a little bit less. So I think everything you said is absolutely correct.
And just one more question in the chat. Any suggestions for scleroderma esophagus when it comes to workup for this?
Don't operate.
Yeah, they run away.
Correct.
Thank you for your wise advice. Dr. Lingaman, you want to just wrap us up? We have a couple more minutes.
Yeah, just the other condition we assess is the eosinophilic esophagitis, which is regularly they do a repeat endoscopy and get the biopsies. But I think we can get a better picture with flip to see where the rings and are developing in the eosinophilic esophagitis patient. And yeah, I think I end up with our what procedure we did on our patient. We did a robotic Heller myotomy, but we didn't use the flip. So I just want to run the video.
I guess while we're waiting for a second, can we just go back to that one? Am I going?
So we started inside and went through the gastrohepatic ligament. Then we mobilized the distal esophagus. Then proceeded with the Heller myotomy. Yeah, it's the esophageal portion. Normally we do like 5 centimeters.
It's funny how more aggressive you tend to be when you're doing it robotically. You feel more comfortable than when it was laparoscopically.
That's the ECD piece on the right of the quadrant. when we do the anterior fundoplication.
What's not mentioned here is that the camera is still in to maintain the appropriate angle, so to minimize any dysphagia. So as you do the anterior fundoplication, the gastroscope is in the distal, all the way to the distal stomach. And also we confirm that the myotomized segment is of appropriate size with endoscopy, making sure we identify robotically the GE junction and that it went well above and well below. But just enough, not too much above, like we usually tend to do with POEM. Here you can actually see it clearly robotically as well. And so we do this with the scope in. The only time a posterior cruroplasty is done is if there is a small hiatal hernia. If there's no hernia, we don't open the area there distally. At this point, usually the scope is being brought out so we can re-examine the angle and make sure there's no angulation at the G junction that was created by the anterior fundoplication.
Perfect. Thank you. Dr. Perry, you want to just give us your final wise words of wisdom?
Sure, I think those are great videos, Verona. Thanks for both of you for sharing that. I guess the only thing I'd like to throw out there before we're done, especially for the trainees on the call, is that one of the worst operations we can do is a Heller that's done for the wrong indication. So workup is really important. I think that one thing we didn't really get to talk about, when you're really concerned about whether somebody has a chronic stricture and aperistalsis versus achalasia, your EGD is really, really important because you have to assess the mucosa and be absolutely sure that you're dealing with achalasia before you do a Heller. And that's doubly important with EJ outflow obstruction because there's so many confounding things that can look like that on a manometry that you have to be really sure from multiple tests, whether it's endoflip, upper GIs, and manometry, that you're really dealing with EJ outflow obstruction, because once you do a Heller or a POEM, you cannot undo that. And if you really were dealing with a reflux problem to begin with, you can really create miserable patient that way. So you just want to be really careful with that. But I just thank you everybody for participating and for inviting me to be part of it. It was really fun.
Thank you so much, Dr. Perry. Thank you, Dr. Lingmameni, Dr. Ross, Dr. Sakandi for putting this all together. As I mentioned, this is actually the last presentation this academic year. So our next will pick up in September. If everyone wouldn't mind just putting on your cameras real quickly so we can take our picture for Twitter. And again, fellows, please watch your inbox for that email regarding the certificate program. Hope everyone has a happy, healthy, and safe summer. And everyone wouldn't mind smiling real quick. Ready? 1, 2, 3.